Bismillahirrahmanirrahim. We have been studying the non-communicable diseases, and we have done previously the hypertension and stroke. Today we will be looking at coronary heart disease, also known as ischemic heart disease. So let's start. Coronary heart disease, also called ischemic heart disease, it is defined as impairment of heart function due to inadequate blood flow to the heart compared to its needs. Uh, it may be caused by obstructive changes in the coronary circulation to the heart. We know that coronary arteries supply the blood and oxygen to the heart. So any obstruction in the coronary arteries may result in coronary heart disease. And since any obstruction in the coronary arteries will give rise to ischemia of the heart, so it is also known as ischemic heart disease. Uh, it causes 25 to 30% of deaths in most industrialized countries or in developed countries, and it is the modern epidemic among other modern epidemics of non-communicable diseases. This is the most important one, and it is a disease that affects populations and the whole communities, and it is not just an unavoidable attribute of aging. You cannot label coronary heart disease or ischemic heart disease uh, as an inevitable result of aging. It is in fact a modern epidemic. So this inadequate blood flow to the heart muscle, which gives rise to coronary heart disease and ischemia of the heart muscle, it may present or it may manifest in many ways. Some of those are angina pectoris. We know that angina is due to insufficiency of blood supply to the heart, and it may be angina on exertion, and it can be angina, unstable angina, which may arise even when the person is aqueous. The second manifestation or presentation of the disease is in myocardial infarction, which happens when the blood supply to a part of the heart muscle is so much compromised that it results in infarction of that part. The third one can be irregularities of the heart. It may be irregularities in the sequence of heartbeat, or it may be other irregularities. Then there is cardiac failure, when there is the cardiac muscle is not functioning properly and the output is insufficient to what is required or needed or normal. And also the coronary heart disease may manifest in sudden death. All of a sudden the person may die due to coronary heart disease or ischemic heart disease. The natural history of coronary heart disease is very variable. There is no one set sequence which will be seen in every person who has the coronary heart disease. It varies in persons in the population, and death may occur in the first episode of manifestation of coronary heart disease, or the death will be the end result of a long history of disease. So there is no set pattern of if we look at the natural history of ischemic heart disease. Despite advances in treatment, we have seen many advances in treatment of ischemic heart disease in the past decades. But despite those advances, the mortality of an acute heart attack is still high. And even if the person survives, around 10% will die among the survivors in the first year, and 5% yearly thereafter. After the first year, 5% of all the survivors every year they will die. So mortality is still high. So we know that the disease prevalence of coronary heart disease is very high in both developed as well as developed countries. But prevalence is not the only measure to measure the burden of coronary heart disease. There are many ways that can be used to measure the burden of coronary heart disease. And all these indicators, all these measures, they illustrate a different aspect of the picture. For example, we can measure the proportional mortality ratio. That will be the proportion of mortality that can be attributed to coronary heart disease. Then there is loss of life expectancy. We know that coronary heart disease cuts short the life expectancy. So calculations can be made for the average gain in life expectation that would follow a complete elimination of all cardiovascular deaths if other mortality rates remain unchanged. Meaning, if you remove the cardiovascular deaths, the difference that will make to the life expectancy, that is another measure of measuring the burden of disease. Uh, then there is coronary heart disease incidence rate, of course. That this coronary heart disease incidence rate is actually the sum of fatal and non-fatal attack rates. You can add them up, the both fatal and non-fatal attacks and attack rates, and you can get the CHD incidence rates. Then there is the age-specific death rate. When analysis is planned to throw light on etiology, it is essential to study the age-specific rates. These age-specific death rates, they suggest or they portray a true increase in incidence. So another measure for burden of CHD. Then there are prevalence rates, of course. You can measure prevalence of coronary heart disease in the community by conducting a simple survey, and you can use ECG for that. You can conduct ECG of individuals in that community, and from those ECGs you can calculate the prevalence of coronary heart disease. Then there is the case fatality rate, which is simply the proportion of attacks that are fatal. Uh, that will give you the case fatality rate. Another measure is measurement of risk factor levels. Uh, so you can actually include measurement of levels of all the risk factors that are responsible for coronary heart disease, and these may include smoking and blood pressure and alcohol consumption and lipid profiles of the individuals in the community. So that can be another way to measure the disease burden. And finally, medical care, which is more relevant for measurement of levels of medical care in the community. So this can be another tool or another indicator that can give you the burden of disease in the community. So these are different tools or measurements or indicators that are used to measure the burden of coronary heart disease in a community or in a population. When we look at the epidemiology of coronary heart disease or ischemic heart disease, you will see that CHDs or coronary heart disease began at different times in different countries. In developed countries, for example, in United States or in Britain, the modern epidemics of CHDs, they began in the early 20th century, 1920s and early 1930s. US and Britain respectively. In other European countries which were a bit late to catch on to the industrialization, the modern epidemic was also, this also started later. And now we are seeing the developing countries are catching up. Developing countries are the sites now where the epidemics are on the rise, and the countries where the epidemics began earlier, for example the US and Britain, they are now showing a decline. The curve is on the downtrend now in the developed countries. The decline in coronary heart disease and mortality in the US and other countries where the curve is on the decline, this can be attributed to, or this can be linked to changes in lifestyles and other risk factors in those countries. For example, diet modification and diet dependent cholesterol, tobacco use, and exercise habits. We are seeing these habits changing in the industrialized countries. They are more diet conscious now. They are The tobacco use has been cut low. In fact, the cigarettes are so expensive in developed countries now that even if somebody wants to smoke, he or she cannot afford those. And also we have seen that in developed countries there are now exercise habits developing, both outdoor exercises as well as in indoor gyms. Uh, so these are some of the factors that can be linked with the declining mortality due to CHD in developed countries. Plus, there is better control of hypertension. We know that hypertension is a major risk factor for coronary heart disease. With the discovery and invention of modern pharmaceutical methods, we have now better drugs for hypertension control. With better understanding of hypertension risk factors, we can modify those risk factors, thus control hypertension, and in turn, we can reduce the mortality due to coronary heart disease. You also have to keep in mind the fact that when coronary heart disease started as a modern epidemic, especially in the developed countries in the early 20th century, we are talking about 1920s and 1930s, it was the disease of higher social classes. And even today, when you talk about ischemic heart disease, the people they usually link this to higher socioeconomic classes in the most affluent societies. But now the situation is changing. There is a strong inverse relationship, in fact, between social class and coronary heart disease. But we are talking about developed countries. In developed countries like US or Britain or some of the Western European countries, the people who are lower on the socio-economic strata, people who are among the lower socio-economic classes, they have higher incidence of coronary heart diseases. So the relationship is inverse, but only in developed countries. In developing countries or in countries which are underdeveloped, the both of the classes, both or all of the classes in the socio-economic strata are at equal risk, and in fact, the mortality among the the mortality among the low socio-economic classes is higher in poorer countries, in underdeveloped and developing countries. Even if the trend is now on the downside, the curve is declining in the developed countries, CHD still poses the largest public health problem. The coronary heart disease is still the most frequent single cause of death among men under 65 years of age in developed countries. So that is something to think about. The etiology of coronary heart disease is multifactorial. There are multiple factors which, in combination, they cause a web of causation for coronary heart disease. Apart from the obvious ones, you know that with increasing age, the chances or the risk for coronary heart disease increases, and also we know that male sex is more prone to coronary heart disease. There are other risk factors, and these other risk factors, apart from age and sex, they may be modifiable or they may be non-modifiable. We know that age and sex are non-modifiable, but there are certain modifiable risk factors which have been identified in the past 40 or 50 years. And some of the risk factors, they they are they give the greater number of the greater chances for the greater likelihood for one to develop coronary heart disease. So let's look at these risk factors apart from age and sex. You can see on your screen the risk factors for coronary heart disease or ischemic heart disease, and these risk factors are arranged in an order which shows the declining importance as we go from up to down, the relevance of the uh, risk factor, this decreases. And you can see smoking is on top, meaning this is the most relevant or the most important risk factor when it comes to coronary heart disease. Smoking the and then smoking has a positive relationship with the coronary heart disease, of course, but with the increasing number of cigarettes that a person smokes, the risk increases. So, and it does not matter if the cigarettes are of filtered variety or of any other variety. So there is a direct relationship uh, between CHD and the number of cigarettes smoked per day. So that is the topmost risk factor. And we have also seen, the studies have also shown that people who stopped smoking, the risk of developing coronary heart disease among them or ischemic heart disease among them decreased significantly. So there is a direct relationship. Then the second important risk factor for coronary heart disease or ischemic heart disease is hypertension. It is the single most useful test for identifying individuals at a higher risk of developing CHD. So it accelerates the hypertension, it accelerates or aggravates the atherosclerotic process, the narrowing of vessels due to atherosclerosis. And if hyperlipidemia is also present, then this process of atherosclerosis, it increases in rate significantly. But hypertension alone can cause an increase in the rate of atherosclerotic process. This is the second most important risk factor. Then there is the serum cholesterol. CHD has been linked with the lipid levels in the blood, as well as the variety of lipids present in the blood. So cholesterol among them, which has an adverse effect when it comes to developing the coronary heart disease. Also, the low density lipoproteins, they give to they give rise to a higher risk for developing coronary heart disease or ischemic heart disease. The high density lipoproteins, on the other hand, have a protective effect when it comes to ischemic heart disease. The next very important risk factor for ischemic heart disease is diabetes. The risk of coronary heart disease or ischemic heart disease is 2 to 3 times higher in diabetics than in non-diabetics, meaning a person with diabetes has a risk that is twice or thrice than that of non-diabetic. Then there are genetic factors. We know that a family history of coronary heart disease is known to increase the risk of premature death, and genetic factors are probably the most important determinants of an individual's lipid levels, and thus they are also in this way indirectly responsible for increased risk for coronary heart disease. Next is the physical activity. We know that with the sedentary lifestyle, the risk for coronary heart disease increases. Hormones have a role to play. The pronounced difference in mortality rates for coronary heart disease between male and female persons suggests that the underlying factor may have a hormonal basis. So there is a theory that hyperestrogenemia may be the common underlying factor that can lead to atherosclerosis and its complications. So hormones have a role to play. Then there are type A personalities. Type A behavior is associated with higher risk for coronary heart disease. Alcohol consumption has higher risk or direct relationship with coronary artery disease. Then miscellaneous, there are other uh, risk factors. Among them, oral contraceptives are one which increase the risk for coronary heart disease. So how can we prevent coronary heart disease? There are various strategies that can be applied, and these strategies which are used for prevention of coronary heart disease, and these include population strategy, a high risk strategy, and there is also of course the secondary prevention. The population strategy and high risk strategy, they focus on the primary and primordial prevention. The secondary prevention is of course the secondary prevention. Population strategy among these may focus on whole population prevention in whole population, or it may focus on primordial prevention in whole populations. So let's look at these strategies individually. So first in population strategy is prevention in whole population. This approach is based on the principle that small changes in risk factor levels in total populations can achieve the biggest reduction in mortality. For example, if you can reduce the blood pressure in your whole population, in your whole community, that will greatly reduce the risk for mortality due to coronary heart disease. The aim of this prevention in whole population strategy should be to shift the whole risk factor distribution in the direction of biological normality. For example, in your population, if the cholesterol levels are higher, you want to shift those levels towards the lower side, towards biological normality in the whole population. It requires this strategy requires the mobilization and involvement of whole community to alter its lifestyle practices that are associated with CHD. For example, I quote you an example. If diabetes is, we know that diabetes is a risk factor uh, for coronary heart disease, and we know that fizzy drinks or carbonated drinks that are usually available in our communities, they have high sugar content, and what you want to do is you want to reduce the amount of diabetics or uncontrolled diabetes in your population. You can do that by promoting a message in your whole population that the sugar containing drinks are not healthier for you, and if the whole population on its own voluntarily decides to cut back on the consumption of sugary drinks, that will result in the whole population of a shift in their blood sugar levels towards biological normality, and that will result in lower risk for mortality due to coronary heart disease. So this is how prevention in whole populations works. So what are the key areas that can be addressed through this strategy of prevention in whole populations? You can focus on dietary changes. As we have talked about the sugary drinks, there are other dietary changes that you can promote. For example, you can promote the use of vegetable oil for cooking instead of desi ghee, say, and you can promote the use of healthier foods instead of fast food, which has high content of saturated lipids and trans fats in them. The second key area that can be addressed is smoking. You can promote uh, the cessation of smoking or abstinence from smoking in your population. We know that smoking is at the top when we talk about the risk factors for coronary heart disease. Blood pressure, if you can reduce the blood pressure, the collective in your the collective measurements of blood pressure in your community towards a normal side, you can do that by promoting you can do that by promoting a message of using less and less salt, sodium chloride in the diets. You can make the whole population reduce their blood pressures towards normal size. That can be a strategy of prevention in whole populations. Then there is a physical activity. You can promote physical activity in the populations. You can do it by health promotion and health education, or you can do it by legislation. If all the residential complexes that are being built are required by law to build a gym in them, or if there are bicycle lanes on the roads or jogging tracks, and so that can result in increased physical activity, and thus helping in prevention in the whole population. So this was the strategy of prevention in whole population. The other thing that you can do in a population strategy for prevention is primordial prevention in whole populations. We have learned about the primordial prevention in our past sessions. You know that primordial prevention involves the preventing the emergence and spread of risk factors before they have appeared in the population. So primordial prevention here will also involve preventing the emergence and spread of coronary heart disease risk factors that have not yet appeared or become endemic. For example, if you can prevent the in societies or in communities where the habit of using uh, packaged food is not yet there, or baked items off the shelf is not yet there, you can prevent that from appearing in that community or in that population, and in turn doing the primordial prevention for CHD. This applies to developing countries in particular, since many of the risk factors that are associated with coronary heart disease are now being introduced into developing countries. So you can focus on preventing the spread of those factors in developing countries. These countries should seek to preserve their traditional eating patterns and lifestyles associated with low levels of CHD risk factors. We know that in old days, when there was not emergence of sugary drinks in our societies, we used to drink water or lassi at the most. But nowadays, the consumption of sugary drinks is increasing. So countries like ours should seek to preserve our own traditional eating patterns. We know that we do make our meals at homes, but that pattern is changing, especially in the urban areas. We have more and more habit of takeaways and dining out. So if we promote our older traditional eating patterns, we can stop the emergence of many of the risk factors. The aim should be to change the community, not the individual subjects living in it. आप पूरी community को focus करना चाह रहे हैं for the primordial prevention, not individuals. So this is the second way of applying population strategy for prevention. Then there is the high risk strategy. In this strategy, you do not focus on the whole population. Instead, you identify the high risk groups in the population. You first identify the risk among those groups, and then you focus on specific advice or specific measures that can be taken to reduce the amount of risk or modify the risk factor in that high risk population. And this way you can reduce the incidence of coronary heart disease in that high risk population. For example, we know that smoking is more present in the adolescents compared to other strata of our population. So you can identify the adolescent population of our community or our country as being the high risk group for smoking, which is a risk factor for CHD. And then you can focus on prevention or modifying of this risk factor by specific advice or by uh, active interventions. Unfortunately, more than half of the coronary heart disease cases occur in those who are not apparently at special risk. So this is one limitation of the high risk strategy. Nevertheless, recognition and treatment of high risk cases do make an important contribution to prevention. Then there is the secondary prevention. We know that secondary prevention aims at early diagnosis and prompt treatment. Secondary prevention in ischemic heart disease is very important because we know that there are survivors after the first attack of the disease, after the first manifestation of the disease. and those survivors we know are at higher risk of mortality subsequently. So, focus on secondary prevention is very important in case of coronary heart disease. The first and foremost in this is lifestyle and behavior modifications. All the risk factors that we talk about in the primary prevention, they remain still relevant even after the disease has set in. Even after the first attack of the disease has happened, the factors, the risk factors that were relevant for primary prevention, none of those lose their importance even after the first attack. So, smoking cessation after the first attack, diabetes control after the first attack, hypertension control after the first attack, all these things which were relevant before the disease had set in, they remain still relevant after the first attack. Thus, this is the first and the foremost thing to be focused on in secondary prevention. Then there are some drugs. There is aspirin, there are beta blockers, there are ACE inhibitors, statins. All these drugs have a role to play in secondary prevention uh, for coronary heart disease. Among all these drugs, beta blockers are the most important, and they have been shown to be the most protective uh, for coronary heart disease. Then there are some revascularization procedures that can be done. For example, CABG, which is coronary artery bypass grafting. You can also do percutaneous transluminal coronary angioplasty (PTCA). You can do valve repair. You can do heart transplantation. This slide here summarizes the preventive measures, the specific preventive measures that can be taken for primary and secondary prevention of cardiovascular diseases. For the last 50 or 60 years, in fact more, almost 70 years, we have been, the mankind has been trying to identify the risk factors which are responsible for coronary heart disease in particular, and cardiovascular, other cardiovascular diseases in general. Not only have the studies or the trials have been focusing on identification of these risk factors, there has been interventions by modifying some of those risk factors, then seeing the effect of those modifications. And these are the studies, these are the trials, or these are the researches which have helped us in knowing everything that we know about ischemic heart disease as well as other cardiovascular diseases. The most important one among these is the Framingham study. This has been has played a major role in establishing the nature of CHD risk factors and their relative importance. The major risk factors of CHD identified by this study have been shown to be elevated cholesterol, smoking, hypertension, sedentary habits. All these risk factors that we have talked about, they have been identified through this study. This study has been going on since 1951. Some of the other intervention trials are Stanford Heart Disease Prevention Program, the North Karelia project, which is ongoing in Finland, the Oslo study, the multiple risk factor intervention trial, the lipid research clinics study. So these are all the risk factor intervention trials which have helped us in identifying the risk factors not only, but also the effect of modification on these risk factors in measurable terms. So these are some of the studies that you have to know about. Well, thank you very much for your time. Have a nice day.